much. We have a very interesting case here. The case
So we have a 55-year male who is a diabetic, well controlled, HbA1c 6.9%. His blood pressure is 140/90. He has dyslipidemia, he is obese, he has coronary artery disease, and he has undergone bypass surgery before. Of course, he has diabetes and hypertension. His body mass index is 30. Now his ejection fraction is 48%. LV dimensions are 48/28 millimeters. He has grade 3 diastolic dysfunction, and his last NT-pro-BNP level was 860. That is quite high for his age. He is on glycerine trinitrate 2.6 milligrams twice a day, metoprolol 100 milligrams, aspirin 150, 20 milligrams of atorvastatin, and 40 milligrams of Telmisartan. Now, what else can we do for his diabetes care and cardiovascular care? Of course, we understand that this is a person who has had an atherosclerotic event. He has heart failure with preserved ejection fraction, and he has multiple risk factors. He not only now has a recurrent ischemic risk, but he also has heart failure. So, of course, this patient and this heart needs a lot more than what we are currently offering him. Ye dil mange more. A combination of SGLT2 inhibitors and GLP-1 would be the most ideal in this situation. We all know that SGLT2 inhibitors will offer glycosuria, will offer osmotic diuresis, natriuresis, will improve afterload, preload. It will also improve the inflammation, it will improve cardiac remodeling, and will improve cardiac outcomes, will reduce heart failure risk, and improve kidney outcomes also. And when you combine this with GLP-1 we know that they improve insulin levels and reduce glucagon, they reduce the gastric emptying, they improve the patient's appetite and satiety, and have anti-atherogenic and anti-inflammatory properties. So when you combine these two, they will offer a very, very good synergistic effect and will reduce cardiovascular endpoints. So together, when you add these two, they will reduce the risk of cardiovascular death. GLP-1 will also reduce atherosclerotic risk, MI risk, and stroke risk. And SGLT2 inhibitors will have an added advantage of reducing kidney outcomes and heart failure outcomes. So when you give them together, you will offer a comprehensive risk reduction beyond what the patient was previously receiving. And it has been shown in multiple trials, whether you give it oral or subcutaneous semaglutide, in the SOUL trial or the SUSTAIN 6 or the SELECT, that these patients receive, when they receive multiple these drugs, you receive cardiovascular risk reduction substantially. So you will achieve a better myocardial salvage. There is an improvement in kidney outcomes. It reduces risk of end-stage kidney disease. It will address residual cardiac risk, MACE endpoints, and will improve the cardiac-free or CVD-free life years. What are the cardiovascular benefits beyond weight loss? In fact, globally, weight loss has been the most hyped effect of GLP-1 but they are not the main effect, they are added benefits. The main benefit is its cardiovascular risk reduction. Over the heart, we have seen that it offers a 20% risk all-cause mortality reduction in the SELECT and the FLOW trials. The ESSENCE trial showed a 37% reduction in the risk of fatty liver disease or fibrosis. Cardiovascular outcome reduction was seen to the tune of 20 to 26% in the SELECT and SUSTAIN 6 trials. The STEP heart failure trial showed a 69% reduction in heart failure outcomes. And the FLOW trial showed a substantial 24% reduction in kidney outcomes. So the benefits are much more beyond weight loss. Weight loss is just one of the benefits. So of course, it will reduce your fat loss. It will cause fat loss. It will reduce your waist circumference by almost 6 inches. 2-point HbA1c reduction is quite robust. 63% reduction in CRP is a huge anti-inflammatory effect. It will reduce blood pressure to the tune of 10 millimeters systolic, 5 millimeters diastolic, and 20% reduction in triglycerides as well. So it is actually addressing all possible underlying cardiac risk factors. It addresses the glucose metabolism, it improves fatty liver and liver fibrosis, improves body weight, not just weight but fat in particular. It reduces MACE endpoints, reduces inflammation, reduces blood pressure, it is renoprotective, it is anti-atherosclerotic, and also reduces stroke risk. What more can we ask from this molecule? The benefits of semaglutide are without any SEMA, they are aseemic. Real world evidence also recommends, shows that the SCORE registry and the STEER registry, where semaglutide was compared with non-semaglutide users, the SCORE registry showed a 45% reduction in the 5-point MACE, that is non-fatal MI, stroke, cardiovascular death, repeat revascularization, and heart failure hospitalization. 3-point MACE risk was reduced to the tune of 57%, and all-cause mortality more than 80%. That was quite robust. And also the STEER real-world registry where we compared tirzepatide with semaglutide, where it showed on the intention to treat analysis, there was a 29% risk reduction in 3-point MACE, and when you go by the protocol analysis, it was a 57% risk reduction. So when you want to just look for weight loss, tirzepatide may be good, but when you also want to offer a cardiovascular risk reduction, it is semaglutide that you must choose. And what do the global guidelines say for this? A lot of guidelines, the ESC guidelines have recommended that whether a patient has diabetes or does not, all chronic coronary syndrome patients should receive GLP-1 as first-line therapy because they have proven cardiovascular benefits. Same has been documented by the ACC-HA guidelines where they give a class 2B indication for all patients to reduce cardiovascular risk, and all patients with diabetes with higher ASCVD risk, according to the ADA guidelines 2025, recommend GLP-1 and SGLT inhibitors as first-line therapy. So I'll just conclude by saying that when you look at the overall picture, when you want to address the cardiac risk, kidney risk, metabolic risk, all the guidelines, whether it is EASD, EASL, they have recommended the same for reduction liver fibrosis and fatty liver. The ESC guidelines recommend GLP-1 to reduce cardiac risk. The KDIGO guidelines recommend the same to reduce kidney outcomes, and the ADA 2025 also offer first-line therapy drug of choice should be GLP-1 and SGLT inhibitors because they reduce cardiovascular risks. Thank you so much. I hope I could stick to the time. Thanks.
Next, we invite Dr. Bharat Sharma to answer the next set of questions. What's the data for tirzepatide in CVOT? Tirzepatide is better tolerated as compared to semaglutide. Is it effective in terms of outcomes without diabetes? Are some of the questions that he is going to answer. Over to you.
Good afternoon, everybody. Thanks for being here for this discussion regarding tirzepatide and its use in patients with obesity, diabetes, and history of coronary vascular disease. So, tirzepatide is the new wonder drug. You already heard from the previous speaker about the benefits of semaglutide, and most of these benefits are accrued because of the weight loss potential of this drug. So, tirzepatide is the updated version of semaglutide. It not just binds to the GLP-1 receptor, it also has an action on the GIP. So, I'll be talking to you about head-to-head trials for tirzepatide versus GLP-1 specifically, and GLP-1 in general and semaglutide specifically. So we have now the outcomes with tirzepatide in CVOT, that is the SURPASS CVOT trial. SURPASS is the entire trial program for non-diabetic patients with obesity where tirzepatide was studied. And in the SURPASS CVOT, it was the molecule tirzepatide was compared to dulaglutide. So this is one CVOT where the comparison of the drug was not against a placebo, but against an active comparator. This was because of a number of reasons. One is ethical. In the face of growing safety of GLP-1 analogs in cardiac patients, it would be unethical to use placebo in the second arm or in the comparator arm. So dulaglutide was used. Secondly, if patients were on a placebo, they would have found out that they were receiving a placebo as there would not have been any weight loss, no side effects would have been there. So the trial dropout would have been much higher. So this was against an active comparator. And you can see that the primary endpoint was reduced by about 8%. It was considered non-inferior to dulaglutide. The upper limit of the confidence interval was 1.01. So this was a significant result. This was what the trial aimed at, non-inferiority to GLP-1 analogs. However, when you look at some secondary endpoints, you will find that when you combine these three primary endpoints along with coronary revascularization, I would draw your attention to the fourth line, which is CV death, MI, stroke, and coronary revascularization. The upper limit of the confidence interval was actually 0.96. So the reduction was quite robust. About 12% reduction in the primary outcome was seen, in the secondary outcome was seen. And all-cause death was also reduced to a significant extent with the use of tirzepatide against dulaglutide, which was to the tune of about 16%. Even the renal outcome was improved significantly. The major benefit was seen in terms of prevention and regression of macroalbuminuria in patients who had chronic kidney disease. So these were the secondary endpoints, although the individual endpoints of the primary composite were reduced but not reached statistical significance. The primary composite with revascularization definitely was beneficial. Now that we have comparison of dulaglutide and tirzepatide, there was an extrapolation of this data, keeping in mind the REWIND trial, which was the CVOT for dulaglutide. And the comparison was done between tirzepatide and a putative placebo. So when this comparison was done, it was definitely found to be superior to the putative placebo, with about 28% reduction in the primary composite and significant reduction in all-cause death by about 39%, significant reduction in CV death or heart failure events by about 30%. This is another trial which shows the benefits in an observational study. This was a large-scale trial, observational retrospective cohort study done in the US, where a number of patients were taken from the US registry, and comparison was done between tirzepatide and GLP-1 analogs. Here, the primary composite outcome was MI, stroke, and all-cause mortality, and there was here a statistically significant reduction of about 40% with tirzepatide in comparison to any other GLP-1 analog. Mind here that the number of patients on tirzepatide were 750 and the number of patients on other GLP-1 analogs were more than 20 to 30,000. But propensity score matching was done, and eventually it was found that tirzepatide was better for primary outcome reduction. Similar benefits were found in myocardial infarction, all-cause mortality, heart failure, exacerbations, all-cause hospitalizations, atrial flutter, and so on. That brings me to the second part of the discussion, which is the side effect profile. Now, the side effects are there to be seen for everybody. Both of these drugs have almost similar side effects because of their mechanism of action. Patients will come to you with anorexia, but that is how the drug works. Some patients present with glycosuria because of SGLT. Not some, all patients who are taking SGLT inhibitors will say that there is glycosuria in the blood, in the urine report. So that is obvious. That is the mechanism of action of the drug. Similarly, any patient who is on GLP-1 analog or tirzepatide will have GI side effects, at least to begin with. So we need to counsel these patients regarding the side effect profile of the drug, how they are supposed to counteract these side effects, how they are supposed to modulate their dietary regimens to reduce the intensity of these side effects, and to reassure them that the side effects persist for the first couple of doses, or when you increase the dosage or escalate the dose, the side effects will increase to a certain extent, but they will usually settle down. And we have usually found that higher the baseline weight of the patient, less is the side effect profile in those cases. Patients who are closer to their normal BMI and are taking the drug mainly for glycemic control, they might expect slightly greater side effects. The side effects being nausea, vomiting, constipation, diarrhea, and so on. And they are comparable in almost all the studies, whether it was used in the SURMOUNT-5, which was in the diabetic patients, or in the SURPASS, which was for the obese patients. In all of these group of patients, there were comparable side effects with semaglutide and tirzepatide. This is the SURPASS CVOT, which is the cardiovascular outcome trial for tirzepatide. Again, tirzepatide was found to have slightly greater intensity of side effects in terms of nausea, diarrhea, decreased appetite. But the points that we discussed earlier, these side effects persisted for the first couple of doses or whenever you escalated the dose. Now, whether it is efficacious in patients without type 2 diabetes mellitus, so definitely tirzepatide is approved for two major indications, one for obviously type 2 diabetes mellitus patients and secondly for obese patients who are not diabetic. So the SURMOUNT trial program was designed specifically to look at non-diabetic obese patients. The SURMOUNT-1 looked purely at weight management against placebo. SURMOUNT-2 looked at treatment now type 2 diabetes mellitus patients. SURMOUNT-3 looked at weight management in patients who are already following lifestyle modification. SURMOUNT-4 looked at weight reduction maintenance dosage. And SURMOUNT-5 was a comparison between tirzepatide and semaglutide for weight loss purposes. And this is probably a slide which all of you must have seen several times. And the numbers here are enormous. So 96% patients lost more than 5% weight. But I would like to draw your attention to the extreme right of the graph, which is more than 62% patients lost more than 20% weight, which is a huge number. And this was significantly better than placebo. This is in the SURMOUNT-1, which is comparison against placebo. But when you compare it with semaglutide, comparison of tirzepatide versus semaglutide in non-diabetic obese patients, again, please look at the last part of the graph, which is on the extreme right. 36% of the patients who are taking tirzepatide lost more than 25%. which is 1 out of every 3 patients, while only 20% patients on semaglutide lost a similar amount of weight, which was 1 in 5 patients. So overall, there is no debate regarding the weight loss potential or the HbA1c reduction of tirzepatide versus semaglutide. That's molecule tirzepatide far outperforms semaglutide there. There might be some doubt regarding cardiovascular outcomes because the data with tirzepatide is still new, it is still coming up, but we have the surpassed CVOT now. Thank you very much.
Well done, Dr. Sharma. You have done in the nick of the time. And now I please request Dr. Sunil Thani to come to the dais and give us some highlights about Finland.
Good morning, everyone. I thank, first of all, Kamal and the Cardiacon team to invite me for this talk today. Last Cardiacon meeting, I've spoken, the signing off line for Finland was that although at this point of time it is indicated for patients with diabetic kidney disease, future will be for heart failure. And in the last year, there has been enough data that has come in to show that this is not only efficacious but also important as an important armamentarium to be used, especially in patients with heart failure with mildly reduced or preserved ejection fraction. So I think the prophecy has come true, so as to say, but the mechanism of action is such that this was bound to happen. So next slide. Yeah. So the question is, can Finland be initiated in such a case of heart failure? The simple answer is yes. We have data now to show that. How is it different HFpEF and HFrEF is that in HFrEF, if you see that it is a consequence of damage to the heart. It's because of the ischemic damage, whether because of inflammation, or it's because of genetic or hereditary, whatever it is. But the heart is damaged and that causes effect on the body. But with HFpEF, it is the other way around. You have obesity, you have diabetes, you have hypertension, you have all these conditions which lead to myocardial stiffness and thereby leading to a HFpEF sort of a situation. So it's heterogeneous disease, and therefore there is no single line therapy for HFpEF as it is today. We need to address this comorbidity, and that is the only way to address a patient coming to you with HFpEF. It is not like HFrEF where you have 4 pillars and it is done. If you look at the approved treatments for patients with ejection fraction more than 40%, of all the options, ARNIs, diuretics, SMRAs, SGLT inhibitors, ACE inhibitors, and so on and so forth, only diuretics and SGLT inhibitors to some extent are class 1 indication, SGLT inhibitors also class 2A in the European guidelines, ARNI is still class 2B. So this is the only thing that we have at this point of time to treat patients with heart failure, ejection fraction more than 40%. The problem is that in spite of all therapies, there is a significant high residual risk of cardiovascular events and mortality in patients who have ejection fraction more than 40. Because of more than 40, we probably think that these patients are safer, that their outcomes will be much better as compared to patients with ejection fraction 40. That's not the case. Because we have so many things to look into when a patient comes to you with HFpEF. It becomes not only difficult to diagnose and to understand the basis of the disease, but also difficult to treat those group of patients. So HFpEF is a more challenging situation as compared to HFpEF when they come to you. By targeting the mitochondrial receptor overactivation matters in heart failure with EKF more than 40%, because there are various pathogenic mechanisms. You have increased activation of the sympathetic nervous system, of the RAS, atrophy, ventricular remodeling, and dysfunction, impaired calcium cycling, and ultimately they all lead to a heart failure situation. And it is actually the RAS overactivation which is the fundamental pathophysiological mechanism in patients with HFpEF or heart failure with mild obesity. It leads to sodium and fluid retention, inflammation, fibrosis, hemodynamic factors, and of course cardiac and vascular hypertrophy, which impacts both the kidneys as well as the heart, leading to kidney failure and heart failure. And therefore, this is one molecule that can be used in both these conditions, and it is the cornerstone of therapy, especially with patients with kidney issues. So it not only leads to kidney damage, but also vascular damage and cardiac damage. And there is both the component of hemodynamic and inflammation fibrosis in this situation. Finland is a distinct selective non-steroidal MRA, and therefore it works very well in this group of patients. It also has it improves the potency of other molecules. For diuretics,
It increases the volume of urine excreted, it reduces the sort of reabsorption, low work in the heart and edema, as it inhibits the reabsorption in the kidneys, and therefore they help the other therapies that are going on. And therefore, it has been studied in both kidney as well as heart failure patients. The final heart failure study, I'll not go into the details, but it's the landmark study which has told us that this is one molecule where it reduces the composite of cardiovascular death and to heart failure events by around 16%. So sustained risk reduction was seen over 30 years, the early separation coming at around 28 days. So by the end of first month, we'll start seeing the benefit, and it continues as you can see, the graph is diverging till the end. If you look at the total heart failure events and patient reported health status, the heart failure events, the change in the cancer's questionnaire for quality of life is better. Across all SS subgroups, they show much more benefit. There's atrial fibrillation, normal sinus rhythm, blood pressure, ejection fractions, background medication, RNAs, whatever it is. Hyperkalemia, is it better? Yes, definitely. We have enough data to show that the protection levels are much more controlled and better when the patient is fentanyl. In fact, I have a problem when the patient is on fentanyl, the protection is still remaining less than 4. And then you have a thought process whether you just have a thought process whether they need to add something more to that or not. So it is actually as safe as that when it comes to the protection levels. When you look at the kidney failure, renal impairment, hyperkalemia, it's a very safe molecule. Not only that, when you look at the androgen effects, that is the gynecomastia or the breast tenderness, the benefits are much more, and it is actually much more safer than spironolactone when it comes to indication for EF more than 40%, yes. Successful trial, yes. Treatment effect regardless of LVEF, yes. Treatment effect regardless of recency of arterial event, yes. Reduce the risk of new diabetes, yes. Reduce the risk of new atrial fibrillation, yes. Risk of sex-related adverse events, very low. Risk of hyperkalemia, low. Selectivity being very high, that's the reason why this is happening. So for EF less than 40%, though you have 4 pillars, for more than 40%, we just have 2 pillars right now. One is atrial inhibitors, one is phendidione, probably semaglutide with its data now coming in, maybe the third pillar that could help in these patients. I'll not go into the details, but enough data has been there on phendidione right now for both CKM. So I'll just sign out by saying that the outlook for patients with EF more than 40 is as good as for patients with EF less than 40. It demonstrated a significantly 16% relative reduction in composite cardiovascular outcomes, and they are consistent across the broad population, regardless of baseline use of SGLT inhibitors or LVEF status. It demonstrated significant benefits, secondary efficacy endpoints, and it was well tolerated, confirming the well-known safety profile with a comparable incidence of treatment to most SAEs to placebo. Thank you for your patient listening.